Hello, 217ers. This is going to be your lecture on burns. I do want to throw it out there to those who chose the original syllabus that any questions on your final exam that are in regards to burns, I will make sure that they are edited to reflect what is presented in this presentation or your reading assignments. Okay, so when we're talking about burns, we're first going to discuss the different types of burns. So the first one we're going to discuss is thermal. Thermal are the most common burns, and those are usually going to be due to some sort of superficial heat source. So you will have dry thermal, and that would be related to like an open flame or some sort of explosion. You can have moist thermal, and that's going to be related to some sort of hot liquid or steam. And then you have contact thermal, and that's going to be when your body or your skin comes into contact with hot metal or tar or grease, some sort of contact with a hot object. We'll go with that. So that is going to be your thermal. So most common is thermal. The next one you have on here is chemical. Chemical are burns that are caused by some sort of toxic or hazardous substance. So the substance can be alkaline or acidic, but it's some sort of caustic agent. And that's going to be like cleaning agents that you might find in your home, like drain cleaner or oven cleaner or bleach, or something that you might find in an industrial setting like caustic soda or sulfuric acid. Those are some of the types of chemical substances that will cause chemical burns. The next one we have is electrical. Electrical is burns are from electric shock or currents that pass through the body causing internal damage. So you can have thermal electric, and that's going to be like an electric spark that ignites clothing or something that links it to the skin. You can have a flash arc. A flash arc is where you have an electrical current that travels from one source to another through the air. Um, One conductor. That's the word I was looking for. So flash arc result from contact with an electrical current that travels through the air from one conductor to another. And then we have conductive electrical injury, and that's going to be when a person touches electrical wiring or some sort of electric equipment and receives an electrical current. So there's lots of potential complications with electrical burns. You can have fractures of bones. You can have cardiac dysrhythmias. You can have a release of myoglobin and hemoglobin, and that will be released into the blood. And then the myoglobin is going to kind of like clog up the kidneys, so it can cause acute kidney injury or even kidney failure. So potential complications with electrical burns, besides those, you can have loss of organ function, significant tissue destruction that may even result in the need for an amputation of a limb, or we can have cardiac or respiratory arrest. And then we have radiation. Radiation burns are going to be due to exposure to a radiation source, and it can be as simple as a sunburn. A sunburn is radiation from the sun using the UV rays. So sunburn are going to be radiation burns. You can also have those people who are undergoing radiation treatment for cancers. They will have significant tissue destruction due to the radiation burns, and that can cause lots of complications. And then you can have radiation burns that are just from being around some sort of machine that emits radiation. Other than those, we can have three other types of burns that I have in my notes is inhalation. So inhalation is caused by inhaling smoke or some sort of toxic fume. It can cause a flame injury or like carbon monoxide poisoning. So those would be some inhalation burns or injuries. We can have friction burns. We talked about that when we were talking about, long time ago, when we were talking about moving patients in the bed. You know, their skin can get stuck to the bed sheets, and when you pull them up in bed, they can get a friction burn from their skin being stuck on the bed sheets. So friction burns are caused when an object rubs on the skin. So we can talk about those in the bed, or you can have rope burns or carpet burns. Excuse me. And then the last one is going to be a cold burn. So that's when our skin has been overexposed to the cold. So frostbite. Frostbite is a frost burn. So before we can talk about all of the destruction that burns can cause to the skin, we need to understand all of the jobs of the integumentary system. And this should just be a review for you all at this point. So one of the most important jobs of the integumentary system is temperature regulation. The skin helps maintain our body temperature through sweating, which allows for cooling via evaporation, and or vasodilation, vasoconstriction that helps with heat exchange. We also have sweat and sebaceous gland function. So our sweat glands excrete water and electrolytes to help our body cool, or the sebaceous glands secrete oils that keep the skin nice and lubricated and protect against dryness and help with that nice intact skin integrity. We also have sensory and organ function. So the skin contains lots of nerve endings that help detect touch or pressure or pain and temperature. And all of that's acting as a sensory organ. So very important, especially with burns, we can have damage to those nerve endings, which is going to decrease all of that sensory function. And then protection against outside organisms. So our body acts as that physical barrier. It's the biggest organ of the entire body, and it acts as that physical barrier to protect us against pathogens and chemicals and different mechanical injuries. So protection from outside organisms, and then also preventing excessive water loss from the body. So when we're thinking about what's going wrong in the body, we have to have a really good understanding what a normal, good, healthy system is, so that we can recognize when it's not working appropriately. So before we get into the nitty gritty of the burn assessment, these are all factors that are going to affect the care of the burn patient. So we're going to need to understand the thickness or the depth of the burn. We're going to need to be able to calculate the total body surface area of the burn. That's going to be really important when we're talking about fluid management. What area of the body has been affected by this burn? How old is the client? Are they a little one, a little child that their TBSA is going to be significant? Or is it an elderly client who has more difficulty fighting off some of the complications that can be a result of the burns? What was the cause of the burn? Was it a chemical? Was it a electrical burn? That is going to affect how we care for the patient. Do we have any other injuries? If they're, say, involved in a house fire, did they have an injury related to the house fire, like, I don't know, a wall falling on them, and then they possibly have internal injuries that we have to worry about as well. And then finally, is there any respiratory involvement? How is that going to affect our treatment? How are we going to identify if there's respiratory involvement? And what is the overall health of the client prior to this burn? All right, so when we're talking about the different factors, this is going to be talking about the depth of the burn. How deep into the skin is the burn of this client? So we're going to first start talking about the depth, and this is going to be the first degree, which is what we we usually know it as. Now they're referring to it more as superficial burn. So a superficial burn is a first-degree burn, and it affects the epidermis, the outermost layer of the skin. So what is going on? What is the pathophysiology? We have this burn, and the burn is causing breakdown of those proteins of the epidermis, and it's causing those skin cells to die or to necrose. So we have collagen damage. So it affects the epidermis. The appearance of these burns are going to be pink, possibly to a reddish color. It is going to be painful. There's lots of nerve endings. There is going to be some mild edema, and that should not have any eschar. So just a slight redness of the uppermost or outermost layer of the skin. These superficial burns are considered dry and intact. So they're going to typically heal in just a few days, very little scarring, if any. And when you're assessing this, they're going to be the burn is going to be blanchable skin. So it'll have that redraw or that capillary refill where it turns white and then it pinks back up. So key features of these, the hair follicle and glands are going to be unaffected since the burn has not penetrated anywhere beyond the epidermis. All right, so our next level of thickness of the burn is going to be our second degree, now more often known as superficial or partial thickness. This is going to affect the epidermis and just a little bit of or a part of the dermis of layers of the skin. So we still have that protein breakdown. The collagen is damaged. We can have the skin is going to start to lose fluids. We're going to have decreased thermal regulation or temperature regulation and decreased sensation to that area. And we have a systemic inflammatory response getting started. So that's going to cause a little bit of a fluid shift throughout the body. Can eventually, it's going to blister. You're going to see blisters. That is predominant in second degree burns. So these are going to be referred to blisters and shiny and moist is what the appearance is. So it's going to have a red to white color. There will be blisters present. The surface of that burn is going to be shiny, and we're going to have weeping wounds or moist wound beds. It is going to be painful. We still have a lot of that nerve ending that have not been impacted. And you're going to still see some blanching, but the blanching is going to be painful. These typically are going to heal within 2 to 6 weeks, and there could be possible mild scarring with these. All right, so the next one is going to be third degree. There's 2 different levels of the third degree, which sounded kind of interesting to me, but they have it identified as a deep partial thickness or a full thickness. A lot of the older texts only went to a third degree, but now we're moving into a fourth degree. So this is like the third degree moving closer toward a fourth degree. So the deep partial thickness, we have damage to the epidermis, we have damage to the dermis, and we have some, could potentially have some subcutaneous tissue or hypodermis damage. The skin on these may look white or black or yellow. It's going to have like a leathery appearance, and there is going to be, excuse me, some moisture. There is nerve damage because of the deeper dermal damage. So they may have no pain, and that's because the nerve endings have been damaged. Deep partial or full thickness burns are not going to probably heal on their own. They're going to require some skin grafting. Um, and before we start doing skin grafting, there may be some eschar or dead leathery tissue over top of the wound bed, and that's going to have to be removed, or you might hear that referred to as an escharotomy. That's going to have to be removed before we can really start doing any of the healing or grafting of that site. All right, so the last one that we have is a deep full thickness burn, and this is your 4th degree. This is going to involve all layers of the skin, may extend into the muscles, the tendons, and possibly even the bone. The skin on the 4th degree are going to appear charred, and the area is often going to be immobile. It's going to require extensive medical treatment and possibly even amputation. I found this picture, I thought it was pretty interesting just to kind of compare the different degrees of burns. And you can see on that 3rd degree area how it kind of has a one level and then it goes deeper. So that would be where you would see the different levels of that 3rd degree. And then that 4th degree, you can see where that tissue is definitely scarred. There's eschar and it goes down into the bone. So this is going to be very, very, very difficult to heal. It's going to require a lot of work, possibly even amputation if they're even survivable. All right, so when we were talking about the different factors that affect our burn assessment, we talked about the thickness and the depth of the wound. The next one on that list was the total body surface area that's been affected. So for that, there's several different methods of measuring it, measuring the TBSA. But the rule of nines is the one that I believe the NCLEX is going to refer to most frequently. There is a rule of palms as well, but we're just going to talk about the rule of nines. So if you can see on this pic, everything kind of comes in factors of 9. So the rule of nines is it gives us a quick estimate of the percentage of total body surface area that has been affected by a partial or a full thickness burn. So it's very, very important for us to understand these rules of 9. So you are probably going to want to embed this picture into your memory so you know what counts as what percentage. That is a hint for you guys. So it's very important that we are able to do this quick estimate so that we can calculate the fluid resuscitation that these patients are going to require. So I am going to preface, if we have anything on your final, it's going to be regarding an adult. I'm not sure if in PEDS you went over the rule of nines or the TBSA for burns, but I am going to review the percentages just because, you know, our kiddos, they have a bigger head and they have a smaller torso. So their percentages are going to vary. They're going to be different from our adult rules of 9. So I'm going to review both of those. So looking at this picture on the adult, we have the head. The head is going to be a total of 9 if it is the full head, so circumferential head. If it is just the front of the head, we'll divide that in half. So anterior head is going to be 4.5 and the posterior head is going to be 4.5 for a total of 9%. In a child, because their heads have a bigger total body surface area than adults, those numbers are going to be 9% for a child anterior face or anterior head and 9% posterior head for a total of 18% just for their head, and that is in your kiddos. So 9% total for a full head in adults, 18% total for a full head in children. Next, we're going to move to the arms. Each arm is worth a total of 9%. Anterior is 4.5, posterior is 4.5. So if they've just burned the end or the front or the anterior part of their arm, that's going to be a 4.5. If it is a circumferential burn, it is going to be a full 9%. So both arms would be a total of 18%. So each arm is 4.5 anterior, 4.5 posterior for a total of 9%. Both arms will total 18%. For our kiddos, each arm is 9%. So it is the same as our adult measurements for the arms. Rule of nines, we're going to move to the legs next. The leg, one whole leg circumferential will be 18%. Just an anterior leg is 9%. Posterior leg is 9%. So a full leg will be 18%. Both legs are going to be 32%. For your kiddos, these numbers are going to be 7% for your front, 7% for your posterior, for a total percentage of 14 per leg. All right, moving to the anterior trunk, it is going to be 9% for the top of the trunk and 9% for the abdomen or the bottom of the trunk. So the anterior chest or trunk in full will be 18%, and the posterior in full will be 18%. And that number is the same for our kiddos. The next one on our adults, yes, folks, the perineum only gets a minor 1%, and the perineum for children does not have a percentage at all. So that is going to be your rule of 9. So if you have a scenario on a final exam where your patient has a full thickness burn of a circumferential, meaning all the way around, burn of the right arm, you would need to be able to calculate that that is a 9% TVSA. And then you're going to move from there for your fluid resuscitation. All right, so for our burns, our partial and full thickness burns, our biggest nursing priority is to maintain cardiac output, and that is going to be through fluid resuscitation. So we are going to use the Parkland formula. Yes, there are other formulas, but Parkland formula is the most frequently used formula to come up with a fluid resuscitation goal. So the Parkland formula is going to use this formula. We are going to give 4 milliliters for every kilogram of the client multiplied by the total body surface area percentage. So once we have calculated that, and we'll talk more about, we'll do one on the next slide. When we calculate that total, it's going to be a big number, tens of thousands. Okay. So once we have that number, we are going to divide that in half. The first half of this fluid total needs to be put into this client within the first 8 hours of their burn. So the first half of this fluid resuscitation, let me rewind. We calculate the number of milliliters that are going to be infused. We're going to divide that by half. That half needs to be infused into the patient within the first 8 hours after the burn. Then the remaining half will be infused into the patient over the following 16 hours. So that should be an idea that you are going to need to calculate milliliters per hour. You're going to need a big old vein. So it's probably going to be a central line. It might even be an intrascalene line. So with this calculation, if you have a patient who was picked up by squad and they get your documentation, or you get your documentation from the squad, and it took them an hour to get to the hospital from the burn site, or an hour after the burn incident, you're going to need to know the total number of milliliters that squad infused into the patient. That total number of milliliters is going to need to be removed from that first 8-hour milliliter total. And this will make more sense on the next slide. So we'll subtract the amount of time en route and the number of milliliters in that first 8 hours. Okay. All right, so this is how we're going to calculate. This is going to be our scenario. We have an adult client weighing 189 pounds. They have been brought to the ER with third-degree burns covering the anterior and posterior surfaces of both legs. The client was transferred via ambulance over 1.5 hours, and in that time, the client received 1.5 liters of fluid en route. Using the Parkland formula, what is the total amount of IV fluids that should be infused at the hospital during the next 6.5 hours of treatment? So you are probably going to see questions like this. So the first thing we need to know is the Parkland formula. And if you remember from the last slide, it is 4 mLs times the number of kilograms of the patient times the total body surface area percentage. Okay. So the first thing that we need to do is calculate the client's weight in kilograms. So our patient weighs 189 pounds, and we're going to convert that to kilograms. So 189 divided by 2.2, and you should receive a number totaling 85.91 kilograms. So the next thing we need to do is calculate the total fluids required in 24 hours. So 4 mLs times our kilograms, so 4 mL times 85.91. We should have probably calculated our total body surface area. So go back to our total body surface area, and we have third-degree burns covering the anterior and posterior surfaces of both legs. So we're going to use our rule of nines, and we need to know, we need to be able to calculate the total body surface area of this adult client for each leg, posterior and anterior. So reviewing, going back to our rule of nines slide, each leg on an adult is 9% for the front and 9% for the posterior. So each leg is going to total 18%. And we have both legs involved in this with this client. So our total body surface area is going to be 32. So going back to number 3, we're going to calculate the total fluids required in 24 hours. So that's going to be 4 mLs times our kilograms, 85.91, times 36. Yes, 36. And that is our total body surface area. So if you calculated that correctly, we're going to round to the nearest whole number, and we will have that this patient needs 12,371 milliliters of fluid in the next 24 hours, or within 24 hours of this burn injury. So 12,371 milliliters. So number 4 is to calculate those milliliters to be given in the first 8 hours. So we have 12,371 total. We're going to divide that by 2. And in the first 8 hours, this patient needs to have infused 6,186 milliliters. So now going back to the question, the client was transferred via ambulance over 1.5 hours, and the client received 1.5 liters. So we are going to use, we need to figure out the remaining 6.5. So we're going to remove 1.5 liters or 1,500 milliliters from the 6,186. So 6,186 minus 1,500. So over the next 6.5 hours, this client needs to receive 4,686 milliliters. So if you had this question and you did all of these calculations, you might see the next question say, what is the flow rate of this for this patient, or what is the hourly flow rate? So in milliliters per hour, how many or what should this IV be infusing? So we know that over 6.5 hours, we need to infuse 4,686. So we're going to divide 6.5 into the 4686, and this person should have an IV flow rate of 721 milliliters per hour. That's why we need a big old vein. Okay, central line, triple lumen, probably interscaling. All right, so that's your Parkland formula. I know it's probably a little bit hard to see it not written out. So if you have any questions about this, please reach out to me and I will put it down in paper format so that you can see that. Or you can reach out to me and schedule time with me, okay? All right, so our priority framework for our burn injuries, how are we going to address these? Well, just like normal, we're going to use our ABCs, but we're also going to use the DE part, okay? So first, we're going to focus on airway patency and breathing. So just to break that down, I also have the different phases of injury. So the first one is going to be the emergent phase. So this is going to be up to 24 to 48 hours after the injury. Okay, so what's going on in the body? We have a burn injury that is causing increased capillary permeability, which is causing that huge fluid shift from the blood to the tissues. So we're going to have swelling, edema to the injured area, but we're also going to have low blood pressure. We also have a huge loss of sodium. We have a loss of albumin, and we have lots, again, that fluid loss. It's just going to continue, so we have to focus on that fluid resuscitation as well. We need to keep that that perfusion going. So this all of this stuff starts at the immediately after the burn and is going to continue to last until our fluid balance has been restored. So we need to be monitoring for fluid loss, lots and lots of fluid loss, hypovolemic shock due to those leaky blood vessels. So we're going to see with our vital signs, we will see a low blood pressure. Our heart is going to work on overdrive to try and pump what volume we do have throughout the body and feed the body with everything that it needs. And then our kidneys are going to slow down because our organs are going to, our focus is the perfusion. So everything else is going to kind of slow down. So we're going to have decreased or low urine output. And then we already talked about the labs. So we need to ensure that we have airway patency. And if we are concerned that we may have a loss of airway, then we need to intubate ASAP. So things to be looking at with burn injuries. We need to pay attention to signs and symptoms of an inhalation injury. So what are you going to see for an inhalation injury? Well, symptoms you might see singed facial hair, singed nose hair. You might see hair that's singed on the neck or on the upper torso. You might see black soot in the nose or in the mouth. The patient is going to have difficulty breathing. They might be wheezy, they might be hoarse, coughing, and they might even have difficulty just talking. And then we also have O2 deprivation. So we could also see confusion and restlessness. So that is signs and symptoms of an inhalation or injury. We also need to consider signs and symptoms of carbon monoxide poisoning. So carbon monoxide poisoning is going to happen most frequently in an enclosed space. And like I said earlier, carbon monoxide is going to bind to that hemoglobin faster than the oxygen can. So it's going to occupy that hemoglobin with the CO instead of the O2, and it's going to block the oxygen from being able to bind to the hemoglobin. And the hemoglobin is what carries that oxygen throughout the body. So that is going to lead to severe oxygen deprivation. So you're going to see hypoxia. However, their O2 sats could still show as being normal, but look at your other signs. Okay, they could have, it's not always, but they could have that cherry red skin in the areas that have not been burnt. And what are we going to do for these? We are going to need to give them 100% oxygen. And the best way to do that is put them in that hyperbaric chamber where they are just infused with 100% good old oxygen. Okay, so those are things that you need to be thinking about with your inhalation and your carbon monoxide. And these are going to be part of your assessment for your airway and your breathing in the emergent phase. Okay. So, So first, our airway, we're checking that for patency and breathing. We're going to check for any injury, inhalation or carbon monoxide injury. Do they have any other compromising issues? Do we need to put an airway in? Do we need to throw oxygen on them? Do we need to intubate? Okay, so that is your A and B. Third, circulation and fluid resuscitation. First, we make sure that they have airway and oxygen delivery. Then we're going to fluid resuscitate them, and we're going to use that beautiful Parkland formula to calculate what their milliliters that they need total for the next 24 hours. So we need an IV access, and we need it now. We also need to, if there's any other injury, we need to control any bleeding or potential hemorrhage, internal or external. We have a lot of the vascular volume has been lost because of this burn. So, and we're constantly losing more fluid through the skin with the weeping wounds. So we need to hydrate them with our fluid resuscitation, and that is going to help maintain that perfusion that the patient needs. Fourth, disability. We are going to assess their neurostatus. We are also, and the disability and exposure, yes, it's going to be part of your emergent phase, but it might be a part of your acute and your rehabilitative as well, okay? But as far as disability goes, check their neurostatus. Do they have any other neuro injury that could be causing a disability or delay? Stroke or shock or whatever, but also where is their burn as far as disability. Burns to the eyes, that is going to be disabling. Burns to the hands or to the feet or to any of their joints, those are going to also affect our care for our patients. And then fifth is going to be exposure. So we're going to be assessing our temperature and our skin. Do we need to put warming measures? Yes, they've been burned, but they also are not able to regulate their temperature anymore. So we need to be able to maintain their temperature, and we might need to put like a warming blanket on them. We need to assess the thickness of their burns, and we need to calculate their TDSA. So that is going to be your exposure. So in your emergent phase, we are ensuring an airway, we're ensuring breathing, we are ensuring fluid resuscitation and perfusion. And then if we get to the D and E, we are going to possibly elevate limbs to reduce swelling and prevent pressure injuries or contractures. Contractures are a big one with those joints, fingers, feet, joints. If we are not managing those areas, they could have contractures because that skin, as it rehabilitates or as it gets treated, it doesn't have that elasticity that our good, healthy, normal skin has. So we've lost some of that. All right, so then your acute phase. Your acute phase is going to be hours 48 to 72 until we have wound healing. So our pathophysiology in our acute phase, we have our body is starting to reabsorb that excess fluid. Our urine output is going to start to increase. Our swelling is going to start to decrease. We have capillary permeability. Our fluid shift is returning back to normal. So everything is starting to all of our internal, all the inner workings are starting to normalize. That doesn't mean that we are at a point where we don't need to worry though. Okay, this is still an early burn. So our goals of care during the acute phase, one, we have to prevent infection. We've lost that barrier to pathogens and microorganisms. So we're going to monitor for any signs and symptoms of infection, fever, wounds, the burns. Are they showing any redness, inflammation, pus development, whatever? Our wound healing is going to be another goal of our care. Do we need to do some sort of debridement to that wound bed? Do we need to remove that old that old eschar and do an eschorotomy so that we can get down to that wound bed and start treating that wound bed? Do we need to start preparing for skin grafting? Pain control. Pain control is going to be super, super important with our burns during this acute phase. And we're going to give medicines to help with that pain. And I think I've got a slide on that. And then our nutritional support for burns, these guys are going to need high calories. Their body is working overdrive to try and heal. We're in this huge inflammatory response. We need high calories. We're going to need high protein and vitamin C. Okay. Those wounds also need good oxygen, oxygen to those wound beds to promote healing. So during this time, we're going to continue to monitor our kidney function. We're going to monitor our GI function. We are going to monitor for infection. We've got all that stuff covered. Okay. Last phase is going to be the rehabilitative phase that can take weeks to years. And this is going to begin. This phase starts once the wound has closed. So this may take, depending on the severity of the burn, may take a long time to get to here. So this begins after wound closure and focuses through that long-term recovery. We're going to have collaborative care with physical therapy, occupational therapy, potentially speech therapy. So lots of different interdisciplinary collaboration. And the whole goal is to promote physical rehabilitation, mental health. These folks are going to need a lot of mental health support, dealing with body dysmorphia and any disability that the burns or contractures could potentially be causing. So that is going to be our rehabilitative phase. So looky here, I just realized I just covered all of this stuff, but your nursing interventions for your burns, maintain airway and ventilation, especially if we have facial burns, provide humidified oxygen. They need oxygen for their lung health. They need oxygen for their wound health and wound healing. Let's see, circulation. We're going to ensure adequate fluid resuscitation using our Parkland formula. We need to also assess for circumferential burns, and that just is those burns that go all the way around like limbs. One important thing that happened, because as those wounds are getting dried up or trying to heal, we can develop that eschar, and that eschar is not elastic or pliable. So the tissues, especially on circumferential burns, the skin is not able to expand or contract with fluid overload or fluid loss. And therefore, if we have an extensive amount of fluid overload into that limb, especially with a circumferential burn, we can develop a compartment syndrome. And compartment syndrome is where there is so much swelling within that limb that it starts to constrict the vessels, and it constricts blood flow to the surrounding area, to any distal area of that limb. And basically, it's going to lead to tissue death or necrosis. So we have to monitor for compartment syndrome. They are going to need an eschorotomy or a fasciotomy. So I've mentioned eschorotomy. That is just removing or debriding that hard eschar or dead tissue off of the wound bed. A fasciotomy, and I was going to put pictures on your slides, but some of them are kind of difficult to see. So a fasciotomy is where, if especially on a burn, where that tissue gets really firm and it doesn't have any elasticity to allow the tissue to expand. In order to save that limb, they will take those patients to, well, some of the burn patients, they'll do it on the burn unit, but they will take them to surgery and they will basically slice. I always use the word fillet down that limb to provide an escape route for that excess fluid. And sometimes they'll leave the fasciotomy open for some time. Sometimes they'll allow it to heal on its own, but it's all in. It's not pretty. I do encourage you to look it up if you have the stomach for it. It's not pretty, but it is definitely required in order to salvage any limbs that might be affected. All right, so that is our circulation and our fluid resuscitation. We also want to maintain urine output at least 30 to 50 mLs per hour. Target output for adults, especially if you have high or low weight clients. Target output for adults is 0.5 milliliters per kilogram per hour. So if you have a very teeny tiny adult versus a morbidly obese adult, you may need to calculate the goal output for those patients. Also with that urine output, we're going to monitor for fluids and electrolytes. So the big ones are going to be hyperkalemia and hyponatremia. We're going to monitor for manifestations of shock. So tachycardia, hypotension, tachypnea, cold skin, lactic acidosis, tissue edema. You know all of these things, right? So all of the stuff that is leading to multiple organ dysfunction syndrome. So if we have to monitor for those signs of shock because we need to resuscitate if it's a sign that our resuscitation is inadequate and we are going to need to up that fluid resuscitation. Okay. We are going to provide pain management, and that's going to be with IV opioids. IV especially because their oral is not going to be absorbed appropriately, and IM they might not have that muscular tissue depending on the severity. So IM is not going to be well absorbed due to those fluid shifts as well. Also super important to remember, remove all jewelry and clothing. We need to keep that patient warm because they've lost the ability to regulate their own temperature. And we may need to, if they have a TBSA that's greater than 20 to 25%, we may need to go ahead and drop an NG tube in them just because they're going to be at risk for a paralytic ileus. Okay. What's next? 7, assess for and prevent infections. We're going to need a very, very strict aseptic technique for any dressing changes. I am going to get to dressings in just a minute. And then nutritional support, we already kind of talked about that. They are going to be in a hypermetabolic state. So we need to have high calorie, maybe even in excess of 5,000 calories or more a day. They're going to need increased protein to prevent tissue breakdown and promote wound healing. And they may also need enteral or total parenteral nutrition as a result of these injuries. And then promote restoration of mobility. That's during our rehab. We want to prevent any contractures or pressure areas because they already have enough skin issues. We don't want to add to that. And we want to encourage range of motion, especially if a joint is involved. We may require splinting to prevent from that skin from contracting and pulling those muscles and tendons and contracting those. So we might need to splint, like if it's a hand, we might need to splint them so that they maintain straight, and then we can do range of motion activities for each one of those fingers. Psychological support. I kind of started on this, but these guys, not only the patients, but their families are going to need a lot of psychological support. They are going to be under high stress because of just what their body's going through, but also they are going to be going through grief. The fear of the unknown. They don't know if they're going to survive. They don't know what they're going to look like. They don't know what their future kind of holds for them. So lots and lots of emotional support for these guys. They're going to have lots of anxiety as well. All right, medications. Medications are going to be primarily pain. So I'll jump down to that. Pain management, we're going to have an IV in. They're probably going to need a PCA or a continuous infusion of opioids, pain management, because, well, one, they might not be able to do a PCA on their own, so they might need a continuous or a basal dosing. But they're going to be in significant pain depending on what area of their skin depth has been affected. So IV preferred because the others, PO and IM, are not going to be absorbed appropriately. So we went IV opioids like morphine or hydromorphone or fentanyl. Going back up for our wound treatments, and I'm going to go into these when we're talking about our wounds, our dressing changes. Antimicrobial creams. They have lost that barrier to microbes, organisms, pathogens, blah, 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 all that stuff. So our antimicrobial creams are going to be really at the forefront for any of our skin and wound care. So you may see silver nitrate soaks. Silver is supposed to be really good for healing and microbe pathogen organism prevention. So silver nitrate, silver sulfadiazine, that is going to be a cream, and it is broad spectrum and water soluble. Methionine acetate cream, also broad spectrum, and it is able to enter those or penetrate, break through the tissue wall. Never use a dressing, so that's going to be on an open exposure treatment. It's going to break through that tissue. We do not want to put a dressing over top of it to absorb it. It can contribute to acidosis, and those wound treatments are very painful. And then bacitracin, we should all know about that one. It's an antimicrobial and broad spectrum as well. This is just a quick slide. We're going into wound care treatments. So there's several different kinds that we're going to break into in depth. Let's see if I can just, yeah. All right, so the first one is going to be an open exposure method. So this is a wound care technique where the burned area is left uncovered after we clean it, and we're going to apply topical antimicrobial agents. So that silver methanide, I can't remember what, I can't pronounce it. But why this is good? It allows for the drainage of those burns, the burn drainage. Well, this is not a good eschar. Eschar can form because it's exposed to the air. It can get dried up, which could cause a constriction or even a compartment syndrome. So we're going to use lots of, you can see on that picture B, they are coating that hand with lots of antimicrobials. So not only is that going to help keep that wound bed moist, but it's the antimicrobials, broad spectrum. When we're doing these dressing changes, we have lost that barrier, remember? So we have lost that barrier. We have got to use a septic technique. We have got to be sterile and prevent any addition to any pathogens to that wound bed. That is why our sterile technique is so, so, so important. And I've told many of you that have had me that, you know, it's a learned skill, but it's such an important skill to really master. Okay. All right. Skin, a good thing with these. You can visualize that skin really well. It makes it a lot easier to assess from nurse to nurse. It allows for us to do range of motion without having to remove any constricting dressings. Disadvantages, it has increased pain. We can lose we are not able to self-regulate our temperature, so we can have heat loss and fluid evaporation. Higher risk for contamination, especially if we don't have everybody using that really good sterile technique. These folks are going to require strict isolation. So they're going to be like on our neutropenic precautions, right? You can't have fresh flowers in the room. You can't have fresh vegetables and fruits, or uncooked fresh vegetables and fruits. Sick contacts. You're not going to be able, like if they have kiddos, they're not going to be able to have their kiddos visiting. And then it's difficult to manage burns with this style of the hands and feet because they're so broadly used. All right, closed method. Closed method, this is a good example of a closed method in this picture. They are going to have gauze dressings wrapped from distal to proximal. The distal to proximal is going to help with that blood flow as well. It is creating a barrier, so it not only is helping with maintaining fluid and heat loss, but it's also helping with a barrier for microorganisms. It does limit your mobility. The range of motion is going to be difficult. So when you're doing those dressing changes, which are frequently every 8 hours, depending on how in depth they are. Some of these people, if it is a huge TBSA, they may be going to surgery daily for dressing changes under anesthesia. These closed method also, it makes it difficult to assess the wound bed as compared to the open. Disadvantages, we do have frequent painful dressing changes, harder to monitor the wound progress, range of motion is going to be harder, and it requires a lot more supplies and time compared to that open method. All right, biologic dressings and tissue grafts. So there are a couple of types. The first one I have is a homograft or an allograft, and this is human tissue donors. So that is going to be frequently cadaver donors, where they might donate their skin. It could be I think that they can get donated tissue if we have somebody that's having a large amount of tissue removed, that can be salvaged for things like this. And most of these, well, all of these are going to, they're only going to be temporary. So a homograft or an allograft is skin from another human donor, and it's going to be applied to the wound bed. This little picture with the different different types of tissue, that is tissue that is going to be a donor. Benefits. It helps reduce fluid and heat loss with these donors. It's adding that protective barrier to help with infection prevention, and it does promote healing until an autograft can be done. And an autograft, auto meaning yourself, so it's a donation when you have tissue that you can get removed and donate to that burn area. So a lot of autograft sites will be like on the thigh area where they have a good flat surface area. So homograft, allograft, they are probably, they are not permanent. They will probably be rejected by the burn victim. It does require sterile handling, does require donor screening to prevent like disease transmission, and it is often used in extensive burns that are greater than 30% TBSA. Excuse me. A xenograft or a heterograft is from an animal source. It is also a temporary skin graft, and it's often going to be rejected because it is not like self, because it is coming from a foreign species. So it'll be temporary until an autograft can be collected. And again, it provides a lot of the same things that the homograft will. Temporary coverage, it reduces heat loss, helps protect against infection, it provides that barrier, and it can decrease pain by covering those exposed nerve endings. It does require sterile prep and screening for any animal disease, but it is used for extensive burns, especially when human donor is not available. The next one is this picture of this woman with the stuff all over her face. That is an amniotic membrane graft. And what they do is they take a donated the innermost layer of the placenta. They take that has been donated, and they have to screen the donor, obviously, for any disease, blah, 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 blah. It's collected after childbirth, and it is good to protect the wound, again, from contamination, fluid loss, pain, blah, 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 all the same stuff. It is also just temporary. It is not from self or autograft, so it's not permanent. It will kind of eventually start to slough off or be replaced once, or they might remove it or remove what can be removed and when an autograft is available. So it does help with decreased infection risk because it lowers the wound exposure. Okay. And then the last one, you've got this arm over here. This is a biosynthetic or synthetic. It's a transparent film. It is man-made materials rather than biologic. And it's used when natural grafts are not available. It does provide a temporary wound coverage to reduce all of those things, the fluid loss, pain, blah, 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 blah. So it gives us a temporary coverage until an autograft is available. Sounds like the rest of them. They are semi-permeable, so they allow for gas exchange, but it allows for air to be exchanged, but it does block bacteria. Some of them are bilayered, so they'll have like a silicone outer layer and a collagen inner layer, and that will help with wound support, cell growth. It again is not permanent and eventually will need to be replaced with an autograft. These, while they're man-made and they're readily available, they are at a higher cost compared to biologics, even with all of the screening that biologics require. All right, guys, this is my last slide, and this is going to be our client education. We're gonna do a lot of education about our complications, and that's going to be with our temperature regulation. It's going to be with our infection risk. It's going to be with our bleeding risk. It's going to be with our risk with circulation because of potential compartment syndrome or eschar. So we need to do a lot of education with our complications or our risks. Okay, but as these clients advance into their rehabilitative stage, they're going to be fitted with these special pressure garments. Those pressure garments are going to need to be worn almost all the time. 23.5 hours a day, which I guess allows them a half an hour to shower. Okay. The pressure garments are going to help with swelling. And you might see lymphedema, people who have had a mastectomy or lymph nodectomy. I'm making up words, I think. But they're at risk for lymphedema, and they wear those compression garments because their lymphatic system has been affected. Okay. Well, these guys might have, they have all of that stuff, all of that deeper tissue has been affected. So they need these pressure garments. Not only to help with controlling the swelling, but it's going to help reduce scarring as well. Okay. We need to encourage these patients. They need to have regular exercise, especially if their burns are affecting mobility or a joint. They need to be involved with their physical therapy. They need to do all of their physical therapy to prevent contractures. And that could potentially be like a lifelong thing where they need to be doing that regular range of motion. If they have other affected areas that they can elevate, that's going to also help with swelling and edema. We want them to keep their skin nice and moisturized. Um, um, there's something I want to say with this, and it's not coming to my mind, so I might throw out a note later because it's about moisturizing skin. I'll put out a note later. So control itching. Anytime we have tissue healing, we will have some itching of that skin. So cool baths and loose cotton fabrics are going to help with that itching. Avoid sun exposure. That skin is going to be at higher risk for burns. So avoid sun exposure. Sunscreens, super important. Wearing protective garments to protect their skin when out in the sun. They are going to have a change in appearance of their skin. Their scars may fade a little bit, but there might still be some redness to that area. And again, there might be some disfigurement that they are going to undergo. And encourage the client to consume extra calories, possibly in excess of 5,000 calories a day. This is probably not lifelong, but during this initial healing phase, they're going to need extra calories and they're going to need protein for that wound healing. So I feel like there might be a couple of other things that I might need to throw out there, but this is what I have for now. I will, as I kind of go through tests and stuff like that, I may put a couple of different announcements out, just FYIs, just to make sure that I've covered everything. But I feel like this was a pretty good coverage of our burn content. So if you have any questions, feel free to reach out to me. I'm pretty much in my email all day long. So reach out to me. Let me know if you have any questions, comments, concerns, anything like that. Have a good night, guys.